Right at the end, yeah.
How's it going? Doing good. Two or three more minutes to go.
Okay, no problem.
Yeah, that sounds good. I think the last hospital. As long as you don't have a seizure, actually, probably not. You have crazy dreams. You never wake up. Yeah, because, you know,
Whenever you get ready.
Okay. You ready to start?
you may have to holler at them when you go.
Good afternoon. Can anyone hear me? Can you hear me okay? Yeah, it's green. Oh, I hear it now.
Move it up.
Yeah. I have 3 boys. I can raise my voice.
Yes, do that. I had 2.
Yeah, so you know. Good afternoon, everyone. I think we're going to go ahead and get started. Can everybody hear me okay? Okay. Thank you so much for having me. I appreciate the opportunity to be here. My name is Anita Generis. I'm a licensed independent clinical social worker and a private independent practitioner. I am the National Outpatient Director for Pathway Healthcare, and I have the honor and privilege to work directly under our Chief Medical Officer, Dr. Stephen Taylor, who is a quadruple board-certified psychiatrist. And interesting fact I always love to throw out when I talk about Dr. Taylor is he's the lead addiction psychiatrist for the National Basketball Association. My boys love that fact. I have 3 boys, and they love knowing that. Can everybody hear me okay? I have 3 boys, so I can speak louder if needed. We're going to start the presentation today. I have a video that is on YouTube. It's from the Addiction Forum in Washington, D.C. This is a video that we actually use with our patients as well and their families. We show this video in order to have them understand addiction as a disease. A lot of times when our patients come to us, they come with so much shame, tremendous amount of guilt, not understanding why they couldn't beat this on their own, and the heavy disappointment that they feel their families and loved ones have in them. So this sometimes brings our patients to an aha moment and is a big part of the psychoeducational process we use with patients.
Scientists first began to understand addiction as a brain disorder in the 1950s. Doctors Olds and Milner.
Is that not being heard?
You may need to unhook your own head. Just hold it over by the speaker.
Let's try it again.
Scientists first began to understand addiction as a brain disorder in the 1950s. Doctors Olds and Milner, in laboratory studies of rats, found the parts of the brain affected by addiction. But then in 1994, Doctors Volkov and Shelbert, top neuroscientists, ran CAT scans of the brain that showed the effects of substance use disorders. Like other diseases, these scans showed it affected tissue function. There are two main parts of the brain affected by drug use, the limbic system and the cortex. The limbic system, located deep within the brain, is responsible for our basic survival instincts. So when you do essential things to stay alive, like eat, drink, find shelter, have sex, or care for your young, your brain reinforces behaviors that cause the release of dopamine from this region. That reward for surviving is also transmitted to the amygdala and hippocampus, which records a memory of that feeling, so we seek it again. This is our survival hardwiring. Addiction also affects this area up here in the prefrontal cortex, which is what separates us from other animals. This is where decision-making and impulse control live. When drugs or alcohol are used, they activate the same dopamine process in the survival center. And when use is repeated, that substance can hijack that part of the brain. This hijacker changes the brain and weakens this system to make it believe that the primary need for survival is the drug. In hijacking the brain, it can usurp those primary motivations: food, water, shelter, sex, and protecting our young. And the hijacker needs more and more of the substance to activate the same level of reward or feeling of pleasure, causing the brain tissue to become increasingly damaged with continued drug use. There are factors that put you at higher risk for the hijacker, including individual factors like genes and age of first use, and then environmental factors like drug availability. But if the hijacker takes hold, addiction is treatable. Advancements have been made in assessments, detox, treatment programs, recovery supports, and medications to treat addiction. Brain scans show that once in recovery, the tissue in the limbic system and cortex can get better. With your help, we can expand these innovations to help millions of individuals and families and ensure that addiction is treated as the medical issue that it is. Together, we can solve this. Join us.
Okay, can everybody hear me okay? Okay. So just to recap, talking about dopamine that gets released when we do things that are pleasurable but also reinforce our survival, and that is the eating, the socializing, having sex, caring for our young. The release of dopamine reinforces these behaviors for us to continue, and memories are made to remind us that these are pleasurable and therefore reinforce the fact that we will seek these behaviors again. The reason addiction is referred to as the hijacker is because some substances actually produce 10 times the amount of dopamine than the natural way it would be released through our pleasurable survival skills. As we know, our bodies tend to work and do work to achieve homeostasis. So the brain's response to 10 times the amount of dopamine is often to stop creating dopamine from the natural sources that we were meant to. And therefore, what ends up happening is the dopamine is being released only through the substance. And over time, that is the only thing that brings pleasure to the individual. And unfortunately, we have seen this when our addiction patients come in and there's DHR involvement with their children. They may be malnourished. We see that all the time when they come in because they have been chasing the drug in order to get their dopamine levels high again. Chasing the dragon. How many of you have heard of this term, chasing the dragon? It has multiple meanings. One of the meanings, of course, is it originated as a Cantonese slang expression referring to inhaling opium or heroin through use of what's normally aluminum foil above a flame. The reason it got its name, chasing the dragon, is because apparently as the smoke rolls off the aluminum foil, it forms the shape of a dragon. However, what most of our patients refer to as chasing the dragon is the fact that they are constantly chasing that first initial high. That first initial high that they got from using that substance is never going to be achievable. And the reason because is tolerance had not yet kicked in, and it will kick in after the first use. The body's natural response is tolerance and that homeostatic response of releasing less dopamine. So our patients in substance use, I don't want to say victims, but substance use patients often believe that that is achievable, and so they will do anything to get to that state of euphoria again. Going back to what was mentioned in the video about the reward system, the one thing I wanted to point out in this slide, and those of you who've ever had teenagers or know teenagers probably already know this, but the prefrontal cortex is not fully developed until about the age of 25. This is the part of our brain that controls our impulses, decision making, thinking, and planning. I have 3 boys, 2 of which are teenagers, and I know this is not even close to being completely formed yet. This also makes teenagers and adolescents the most vulnerable population because the rushes of the dopamine, they're already not fully developed in their prefrontal cortex to control their impulses. And so what ends up happening is they become heavily addicted even as a young age, and this becomes their coping mechanism. The American Society of Addiction Medicine has defined addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, physiological, social, and spiritual manifestations, which is reflected in an individual's pathologically pursuing reward and relief by substance use and other behaviors. What's important, I think, about the definition is the second paragraph as well. It is characterized by the inability to consistently abstain from the substance, its impairment in behavioral control, the presence of cravings for the use, diminished recognition of significant problems with one's behavior and interpersonal relationships. We see a lot of our patients that come in, they do not have the insight or the judgment to see the impact that the substance has actually had on their lives, whether it's destroyed families or whether it's cost them their life savings. We've had some folks that come in when they're first seeking treatment, and when the question is asked, how much have you spent on this substance? We've been told sometimes $2,000 a month. And to them, that's okay. They'll find the money. They will get the money because they are going to chase the substance. And so by the time they come in, they are ready to get help. But again, they've probably been through so much at that time, they've lost an awful lot and are in need of intense therapy and some case management assistance. So what, if anything, constitutes effective evidence-based treatment? And I need to mention this because Dr. Taylor added that, and it's very true. It's very different from what most people do receive today, and we're hoping to be on the forefront of changing that. There's over 4 decades of evidence-based research that has yielded 13 fundamental principles that characterize effective treatment for people with drug addictions. We're going to go over those principles, and these have been adapted by the National Institute on Drug Abuse. And the last update was in January 2018. The 13 principles of drug treatment is addiction is a complex but treatable disease that affects brain function and behavior. Abuse of drugs alters the brain structure and function, resulting in changes that persist for long after the drug has ceased. This is one very important aspect because even folks that have been sober and clean for a long period of time are still prone to relapse. We call these things triggers. You never know what could take a person, even in long-term recovery, what could trigger that person to use again. No single treatment is appropriate for everyone. We have a saying that recovery by any means possible. Some folks believe in abstinence and that is the only way that they could achieve recovery. Others support medication-assisted treatment. Not one is good. There's not one answer for every individual. We all come from different backgrounds, different histories, different substance use histories, and different substance preferences, and so treatment cannot look the same. Treatment needs to be readily available. This is one thing that has been a challenge. A lot of folks who are on Medicaid or have case management needs don't have the same access of care to those who have commercial insurance or can afford to pay cash paying for their treatment. Because drug-addicted individuals may be uncertain about entering treatment, it is so important that we strike when they come to terms with the fact that they want help. In fact, what we've experienced in our agency is that if we do not get them, if they're in the hospital and they say, okay, I'm ready for help, this is my rock bottom, I don't want to overdose again, I don't want to die, it is imperative that we get them before they discharge home. It is imperative that they come into treatment and start that recovery process right away. What we have found is if they get discharged from the hospital and they go home, they're back in that using environment. Their friends have all, most of the time, are users as well, and so we've lost them. We have got to strike when the iron's hot, when they decide that they're ready to take that leap and make a change in their life. Effective treatment attends to multiple needs of the individual, not just his or her drug abuse. I spoke earlier about case management, and a lot of our patients, when they come to us, they have hit their rock bottom, and they have needs such as financial needs, maybe transportation needs, health insurance, perhaps they've lost their job, they're in the middle of divorce and need some legal aid. It's treating the whole person that is important and actually assist in their recovery process long term. Oops, I'm sorry, I skipped ahead. Another big consideration in effectively treating drug addiction is the length of the treatment program. Research has indicated that it needs to be at minimum 3 months, and in fact, longer-term treatment programs have shown better success for long-term recovery of the patient. We'll go a little bit more into detail about what options there are and what the differences are in those options as far as the intensity of treatment. Behavioral therapies. These include individual, family, or group counseling and are used oftentimes to decide the motivation to change within the patient, provide incentives for abstinence, getting the patient to think about why they would want to change, what the reward would be for changing. Saving $2,000 a month might be a big one. Medication-assisted treatment, I mentioned that earlier. Medications are an important element of treatment for many patients, especially combined with counseling and other behavioral health strategies. Methadone, buprenorphine can be used. Long-acting formulations are effective in helping individuals who are addicted to heroin or other opioids. For alcoholism, Vivitrol is often used. Naltrexone can also be used for alcoholism. It is substance specific, so there are medications that over time can help curb the cravings for the individual and lead to better success in their recovery. An individual's treatment and services plan must be assessed continually and modified as necessary to ensure that it meets his or her changing needs. This goes again with the fact that not all recovery can look the same. A patient may require varying combinations of services and treatment components during the course of treatment and recovery. Family therapy is key. Getting the family to understand that this is a disease is big, because again, our patients come in with so much shame and guilt, and a lot of times the family doesn't understand addiction as a disease either. And they don't understand why their significant other cannot stop, why their son will just not stop, while their mother continues to drink. So psychoeducation is really a huge component of treating addiction, and not just for the patient. Many drug-addicted individuals also have mental health disorders, what we call co-occurring disorders. This begs the question, what came first, the addiction or the mental health disorder? Until a patient is medically stable, it is very hard to assess what co-occurring disorders may exist. And that's why it's extremely important that there's an interdisciplinary team approach when it comes to treating addiction. Medically assisted detoxification is only the first stage of addiction treatment. Medically assisted detoxification is extremely important, but if it stops there, it lessens the likelihood that recovery will be long-term for the patient. After detoxification occurs, the patient needs to be in either an IOP, an intensive outpatient program, or an OBOT, which we will go over, which is an opioid-based agonist outpatient treatment program. Treatment does not need to be voluntary to be effective. That's an extremely important principle. A lot of folks say, well, you can't change a person until they're ready. I worry about when I hear the term rock bottom. Well, just wait. When that person hits rock bottom, they'll be ready. The problem with our patients with addiction is rock bottom is death. They don't stop until it's too late. So I am always very careful, and I try to educate family members as well, is rock bottom for your sibling, for your son, for your daughter, for your mother, it could be death. And in fact, there was one situation we had that I'll share with you recently where a 28-year-old friend of a patient came to one of our facilities, and while sitting in the waiting room, decided to snort some oxycodone. This was not one of our patients, was not coming to see us to overcome her addiction, and actually ended up passing out and was not brought back to until 2 doses of Narcan were administered. She is now one of our patients, but rock bottom for her would have been to overdose and die in our facility. And so it's really an important component to remember that even if a patient is not voluntary, it's okay to seek treatment for them. It's okay for us to involve the family members and to encourage the family members not to wait until the patient hits that rock bottom. Thankfully, again, the happy ending to that story is that this is a patient, and I'm hoping and praying she will be our poster child. And she was very, very happy to know that she has come to grips with the seriousness of her addiction and ready to get help. Drug use during treatment must be monitored continuously, as lapses during treatment do occur. Knowing their drug is being monitored can be a powerful incentive, and this is true in any program. It's a big incentive and motivation if they know that when they come in to seek treatment, they are going to get a drug test. You know, and I will say, that's not foolproof. We know all the wonderful technology there is out there. It's mind-blowing if you ever Google it to see how to get past a drug test. It's a market in itself all on its own. But for our patients who are serious about their recovery, when they come in and they know they are being drug tested, a lot of times they don't want to let themselves down, they don't want to let their families down, they don't want to let our providers down. So they're actually more willing and motivated to come in with clean drug screen. Treatment programs should test patients for the presence of HIV, AIDS, hepatitis B, infectious diseases, tuberculosis. Again, addiction does not discriminate. And a lot of our patients have already been exposed or are at risk if they haven't already been, especially when it comes to intravenous drug use. So this is something that needs to be addressed. Protection needs to be discussed with the patient, and also the patient be able to know where they can go to get tested, and then if a test is positive, where they can go to get help. I spoke earlier about the differences in addiction treatment facilities. Some of this you may know, some you may not have heard of before. Most of us know there's inpatient acute and there's inpatient residential or long-term facilities. There's pros and cons to each one. The inpatient acute and residential facilities can offer detoxification and stabilization all the way to residential living programs where they on average will go from 3 to 6 months. Most do utilize either an interdisciplinary or multidisciplinary team. So you have a psychiatrist, you have a nurse, you have a behavioral health provider. However, one of the downsides that we've seen from this is if a patient is discharged from an inpatient facility and there isn't a coordination of care upon their discharge, they don't really know how to handle life without going back to that substance. And the reason is, while they're inpatient, it does not mimic real-world challenges to staying sober and being able to cope without the protection of those walls and someone having your food ready for you and the stressors of life that aren't really mimicked well in an inpatient facility. IOPs, or intensive outpatient programs, can be utilized after acute or inpatient treatment. The patient is provided treatment services for 3 to 5 days a week in an IOP, meaning they are not inpatient, but they are coming 3 to 5 days a week, several hours each day to receive care. One of the challenges to an IOP is often the cost and the time commitment for the patient, and it makes it difficult for them to access care. You can imagine in your day-to-day life, 3 to 5 days a week, several hours each day, going and seeking treatment. Both our patients have to work, have to have income, and so that does make it a challenge, as well as the cost of intensive outpatient programs for those who are underinsured or uninsured. Office-based opioid agonist treatment, or OBATs. This is the medication-assisted treatment. It is outpatient. Most widely known to the public as Methadone Clinics. A lot of people I talk about, when I talk about OBATs, say, oh, I know all about you guys. You come in, the doctor writes the script, you collect the money, and the patient leaves. And that's unfortunate, because not all OBAT programs are the same. They differ widely depending on state regulations. For instance, an OBAT in Tennessee has to and mandates by the state that there is a board-certified addiction specialist on staff, but also a case manager to address the management needs of the patient, a behavioral health counselor. The patient also has to have counseling during treatment, and a peer recovery support specialist. This is someone who's in recovery themselves and has been certified in order to provide supports for patients. Tennessee is one of the leading states in the nation that is really making it an interdisciplinary approach when it comes to treating addiction. The approach that we use, as I was speaking about earlier, is the interdisciplinary approach. Impact behavioral counseling is our counseling side of Pathway Healthcare, and Pathway Healthcare consists of the medical treatment team. There is a difference between multidisciplinary and interdisciplinary teams. Multidisciplinary teams have members that work independently, and they interact formally with little or no awareness of the other discipline's work. Appropriate experts from different professions handle different aspects of the patient's case independently. Interdisciplinary teams is a group of professionals that work interdependently in the same setting. Separate assessments may be conducted, but team members work to achieve a common goal. There is both informal and formal communication when it comes to the patient. Therefore, the medical provider is informed by the counselor, and the counselor is informed by the medical provider what is going on with this patient, and they take a very holistic approach into how to best treat the patient and meet the patient's needs. It's a constant process of communication and collaboration, which involves the patient as well. Behavioral health approaches we use. Psychoeducation is a big one, again, not just for the patient, but also for the family members who support the patient. Psychoeducation includes understanding addiction as the brain disease, but also the triggers. A big part of the beginning of recovery is having the patient be able to identify what their triggers are. And oftentimes, their trigger is a person. Their trigger is their friend that they used to hang out with and they used to go drinking at the bar, and then, getting some cocaine or something. So triggers need to be identified so that then there can be a plan on how to avoid them and what to do when the patient is feeling triggered to use. Motivational interviewing helps with ambivalence. There's stages of changes. You walk the patient through. Are they in pre-contemplation stage? Are they contemplating change but still a little bit anxious about it, not knowing what they would do if they didn't use, or preparation. Are they preparing to change and ready? And the next stage, of course, is taking action and becoming involved in a program to support recovery. Cognitive behavioral therapy, it helps patients become aware and modify their dysfunctional thoughts, emotions, and behaviors. CBT focuses on solutions and encourages the patient to challenge the distorted and negative cognitions and change their destructive patterns of behavior. DBT, Dialectical Behavioral Therapy, introduced by Dr. Marcia Linehan from Washington. This is emotion regulation, understanding and identifying emotional mind versus wise mind, how to get from emotional mind into wise mind, and identifying emotional triggers and planning crisis planning for when emotional triggers arise. This DBT is very efficacious with personality disorders. DBT is commonly used with folks diagnosed with borderline personality disorders and has proven some success. Mindfulness-based relapse prevention has been used effectively to treat and mitigate a wide range of behavioral health issues, including depression, grief, anxiety. It encourages the patient to be aware of the body cues, the tension that they may feel, and practice relaxing the mind while accepting the present experience as it is, not judging. The reason this is such a good approach with our patients is because there's a lot of self-judgment. And so getting them to understand what has happened, look at it from an objective point of view, and not judge it, but accept it, really helps them to move forward and break out of that cycle of the guilt and shame. Types of therapy offered. We offer individual therapy, family therapy with the patient present, family therapy without the patient present, of course group therapy, and telehealth has been a major component of what we use. A lot of times we have patients that aren't able to get to the office or may have some challenges or may bond with a counselor at a remote site, and therefore in order for us to be able to provide them the care they need, we do offer telehealth services as well. The behavioral health tools and instruments that we use include the PHQ-9 and PHQ-2. This screens and monitors depressive symptoms and severity. The Adverse Child Experience, ACEs. Has anyone heard of the ACEs before? This was actually a study done by Kaiser Permanente in conjunction with the CDC, and it was based out of Southern California. What they were finding is that the people that they were treating for obesity were starting to slowly report some adverse childhood experiences, some abuse, some neglect from a parent. And so what they realized is they wanted to do a study to find out the impact of these adverse childhood experiences on adults. And what they ended up finding was that the high scores, like if there were more adverse childhood experiences, there was more of a likelihood, not only would there be more severe behavioral health problems, but also medical issues. It increased the likelihood of diabetes. It increased the likelihood of many of the medical high blood pressure diagnoses. And so this is important because a lot of our patients don't even realize these things were happening to them, and they take this 10-question ACE form and they realize, oh my gosh, that did happen to me. Oh yes, oh my gosh. And it's an eye-opener for them to understand how the impact of their childhood, what it has had on them as an adult. Columbia Suicide Severity Rating Scale is a tool that is used. There's a triage version, short screen, and a lifetime one. This is used if there's a presence of suicidality. The GAD-7, that's our general anxiety disorder scale. We give this test when there is some medical stability, and so what we're getting is more accurate. This basically rates how anxious they've been feeling, how often they feel that anxiety. Again, a lot of our patients, they've been coping through using substances, so they haven't gone through that natural development process in their lifetime to understand and to grow about how to cope with stress, how to cope with negative emotions, what to do that would be healthy in order to process those emotions. And so all they've really known is to take a substance and to get rid of that negative emotion. PTSD, Diagnostic Scale. A lot of the patients that we have had some sort of PTSD in the past, also chronic PTSD, where their current home situation is less than healthy, or violence exists, or neglect. The Y-box scale is to rule out obsessive compulsive disorder and behaviors. Brief addiction monitoring tool. This is an outcome measure that was developed by the Veterans Administration, and it assesses the risk factors and outcome measures for military veterans. However, because it provides scores for 3 factors, which is use, risk, and protective, it makes a wonderful outcome measurement tool for those using substances. When a patient comes into Pathway Healthcare, they initially see the medical provider for a full assessment. At that time, a counselor goes out and does the meet and greet and lets them have a warm welcome, face-to-face introduction to the behavioral health counselor. What we've seen for some of our new patients is when they walk in, they're willing to see the doctor, and their response is, I'm not crazy, I don't need a counselor. And so this allows us the opportunity to be able to give them a warm welcome, make them feel safe, and know who the counselor is going to be that they will be seeing. On their second visit, this is 1 week from their first medical visit, they'll come back to see the doctor. The doctor will go over how their medication is working, and then they will see the counselor for their full assessment. This continues into the induction phase for a month. Afterwards, they will come in monthly to see the doctor and monthly to see the counselor unless they request otherwise or need a higher level of support. Maintenance behavioral health visits are traditionally monthly, where they'll come in and they will see both, again, the medical provider as well as the counselor. And again, that interdisciplinary approach is significant in how we are able to treat the patient holistically. A lot of times the patient may not say something to the doctor, but they come back and see the counselor and say, my wife's leaving me. It's important that we know that the stress level is probably up for this patient, that that's likely going to be a trigger for this patient, and maybe that's time to have kind of a team meeting and think about how his or her treatment plan can be altered to support the better outcome for the patient. This is just a list of the references and the resources. All of them are certainly worth taking a look at. As I said earlier, the most vulnerable population we have are teenagers and adolescents, especially those who have been exposed to substance use, whether it be by a family member. These days, I know there's a lot of synthetic drugs out on the market. And unfortunately, a teenager does not know what they're getting even when they decide to smoke marijuana. I know there's the vapes out there, and there's all kinds of amazing ways to hide the drugs. In fact, in one of the high schools locally where I am, the thumb drives are really popular, but they're little vapes. So they can walk around the school with them, they can have whatever they want in them, and when the teacher isn't looking, they're smoking their thumb drive. And we've all heard the horror stories. But again, so number 6, where it says the parents and educators, that's really a great website to go on and learn and educate ourselves as providers about what's out there. Because it's amazing the amount of things that they're willing to hide, they are able to hide now and buy right online. Okay. I didn't paste too much, right? Okay, good. Any questions that I can entertain at this time? Yes, sir.
On TV, they've been talking about the problems in San Francisco, Seattle, and Los Angeles. I stepped out for a minute, so I don't know whether you discussed it. As your group trying to do anything with these homeless that are on the street?
What we have done, what the question was, is that you mentioned San Francisco, Los Angeles, and the homeless population. And are you asking, are we targeting that audience as well? Are those?
Yes, is there some program set up to specifically involve those people?
We do try to make our care as accessible as possible. We are in the middle of contracting with Alabama Medicaid We do accept Medicaid right now, and if for their medical care, and while we're waiting on the behavioral health contract, we go ahead and see them right now and provide them the behavioral health care that they need. As far as homeless goes, that's where our case management team would come in and try to get them plugged in to whatever resources they need, including assistance with job seeking, shelter. Absolutely. We don't exclude anybody from care, and we certainly would help them the best way we can. Now, we're not out in San Diego and Los Angeles and those places right now. The states that we are located in are Tennessee, Alabama, Mississippi, Texas. There should be Tennessee, Alabama, Mississippi, Texas. We're moving into Louisiana. Mm-hmm.
So there's not a specific program that the government set up or anything to target those people?
Not yet. Nothing that that the federal government has set up. I know a lot of the patients that we've had and I've experienced in my career, we have a lot of veterans who suffer tremendously with substance use disorders. And so, of course, the VAs, we reach out to the VAs for support of our veterans. Any other questions? Well, I thank you all. Oh, go ahead. Yes, sir.
How is marijuana legalization affecting the drug addiction problem? Is there any stats back there?
There is some controversy. There is some controversy that, okay, if you have somebody who's coming in to get treatment for their addiction and they've mainly been addicted to heroin and using it intravenously, if they decide they're going to get clean yet they're still using marijuana, what's the fine line there? You have some people that say, hey, marijuana is not going to be fatal. You know, when you test them and they're positive for marijuana, don't bump them back to come back earlier. And then others that say, well, marijuana still really is that drug that leads to other substances, and they're still not learning coping abilities, you know, to deal with the life stressors. And so that is a big controversy. And now with Alabama having their first planted marijuana field, I saw more to come on that. More to come on that. I'm sure the Al-Sam is going to have a lot more to say about that. But it's interesting, the arguments. I mean, kind of the Clean Needles initiative, you know, so there are strong feelings on both ends about that. Right now, if they come in and they test for marijuana, they're meeting with our counselors. We're going to address that with them. We will want them to learn coping strategies without having to go to a substance to deal with life. Did that answer your question?
More or less.
Yeah. I mean, it's definitely made it difficult. And I will add to that, some states have stronger regulations than others. I mean, you can open up an OBOT, and if they test for marijuana, that's okay. Some don't require that you test for marijuana. You only test for these substances. So it's more regulation, I think, is probably going to be coming down the line. Anybody else?
Can the hemp that they're growing, I understand it usually, that's allowed by law, has a much smaller amount of marijuana activity in it. Can that be distilled down by people to be as strong as what they might get?
Well, I will say there's a lot. I'm sorry, what he was asking is that you were talking about hemp and people being able to maybe distill it into a stronger substance. That's a great question. I will say there's a lot of creativity when it comes to substance users. And I'm not sure if they are able to distill it. I will say CBD oil has gotten very popular. It's being sold on the internet. I know that when you drug test, it will still pop positive. And I've had people say, no, it's not supposed to, but it has. We've experienced that where they've only used CBD oil and yet it is still popped positive, tested positive for THC in their system.
Well, they could have a big party and set the field on fire. That might still work.
They could. Anybody else? All right, I have some cards, Lisa. Thank you very much. I have some cards, Lisa, I'd love to hand out.